Good morning, everybody, and thank you very much. Thank you, Alison. Thank you to RA UK and the organisers, and particular thanks to Nigel Bedford for his comments on how good it is to do awake shoulder arthroscopy. So, a lot of you do know me, but many of you don't, so I'm just going to spend a few minutes just telling you a little bit about me. So, really over the last 12 years as a consultant, the three things that I've spent most of my time doing is actually acute pain, day surgery, and regional anaesthesia, with a little bit of management, which I'll tell you about. So I have been and still am the lead for acute pain in a hospital. I've also been the lead for day surgery, and regional anaesthesia has always been a passion of mine, particularly ambulatory peroneural catheters. And really throughout, I've always tried to take on positions where I may influence change in patients' care. For me, that's always been my motivation. So over the last probably more than 4 years now, I've been using short-acting spinal anaesthetics in day surgery. Prior to that, to be honest, I really didn't do spinal anaesthetics in day surgery. And it's really just been revolutionary and absolutely fantastic, and I've really not understood why other people don't do it. In South Africa, there was this really great advert, guy selling razor blades, and he says, this product was so good, I bought the company. That's not exactly what's happened to me, but I wish. But over the last year, I was approached to become the medical director of Synthetica, which is the MA holder, or the marketing authorization holder for these short-acting spinals, the chloroprocaine and prilocaine. And I really leapt at the chance, not only just a chance to do something different, but also a chance really to influence change on a far greater scale. I think it's probably a fair comment to say that as anaesthetists, we always keep quite a low profile. And that I think sometimes our efforts are underappreciated, and our attempts to actually improve patient care are often taken for granted or otherwise ignored. And I really believe that short-acting spinal anaesthesia and day surgery is a chance for us to improve patient care, for us to demonstrate our value, and to take on a leadership role to actually change patient care pathway in this way. So I pose two questions to you. The first one being, who thinks that general anaesthesia should be the default technique in cesarean sections? So I wouldn't expect a lot to go up, but yeah, there are a few. Good, okay. And the other question is, who thinks it's a good idea to perform hand surgery awake simply just under a regional technique? A little predictable, I suppose. So, you know, I think really that what we've got here is an opportunity to use spinal anaesthesia in a very similar way to actually influence a change for patient care in a better way. So I thought, before I start, let's have a look at what we've got at the moment. What's general anaesthesia? So I went to NHS Choices, first of all, just to see what we're telling the patients. So in the introduction of general anaesthesia, they say to us, well, it's not exactly clear how it works. I mean, that's not really reassuring, is it? And the truth is, we don't even understand the state of unconsciousness. So how can we actually say to patients, you'll be all right in the state of sleep that we induce to them? The three of the greatest concerns that patients have under anesthesia or even surgery is that they'll never wake up, they may wake up in the middle, or that they're going to die during the operation. And to me, these are really within the territory of general anesthesia, certainly the first two anyway. And I think perhaps our motto of 1932, Insomnia Securitas, is something that we should move on with. Oh, goodness me. That's the problem with having big thumbs. So naughty buggers. So we should move on from this older motto of ours, Insomnia Securitas, and be more progressive with our college's motto, It is divine to alleviate pain. Perhaps that is really our focus. I thought, look, there's got to be reassurance from my college somewhere, so I went to some of the other patient information that we give on general anesthesia. And right at the bottom, there is a little bit of reassurance, because there is an advantage of general anesthesia, and that is you will be unconscious during the operation. But I would say, in fact, you may be unconscious during the operation. So that's what we've got. I thought, well, what have we got for the patient at the moment, actually? And really, it's been the same for a long time. And it depends on the source that you go to, but there's a lot of pain, there's a lot of nausea and vomiting, but also these neurological symptoms, quite a bit of headache, sedation, quite a big percentage, really, dizziness, tiredness. And seriously, is this all we've got? Is that what we give patients? I mean, surely they deserve more than that. So what's the ideal technique? I mean, this might seem a little bit of a rudimentary question, but I think it is fundamental. So the ideal anesthetic technique should be safe, should be of high quality, reproducible, high success rate, that is, efficient, fast, and cheap. So I actually found this from a previous presentation, but it's on the Ezra Academy, where they describe spinal anesthetic, and it is versatile, easy, efficient, low side effects, less postoperative confusion, less cognitive deficit, and very cost efficient. Well, that's the end of the debate, really, isn't it? It really is done. But I think there's more to show you, and I'd like to show you some of the benefits of spinal anesthesia. And first I started with, well, you know, I'd hammer through patient, surgeon, da-da-da, but I thought maybe it would be far better, and perhaps like Nigel showed a video, that's what I should have had, you know, showing the journey of this young bloke that comes in for his knee arthroscopy. And he's had all the information, he's chosen to have the right anesthetic. So he's awake during his procedure, has his headphones on, or checks his emails, or whatever he would like, but then starts engaging with the surgeon, looking at what's happening in his knee, actually has his consultation there as to what's going to happen afterwards and what's going to follow up. Doesn't have to go back to the PACU or the first stage, but go straight back to his bed space, neurologically completely intact. And as I say to the patient, the way you're feeling now preoperatively is the way you're going to feel afterwards. Has a cup of tea and toast, settles down, the block slowly wears off, not that slowly, and he's able, because his mental faculties are still with him, to start coping with the discomfort that may occur after the arthroscopy. Not feeling sick, not feeling nauseous, dizziness, any of those problems. I think even greater benefits than this, of course, he'll be discharged without any urinary symptoms the same time he will with a general anesthetic. And I'll show you that a little bit later on. But he won't have to have a chaperone with him at night, because he hasn't had a general anesthetic. So instead of being admitted to hospital, he can just go home. He won't have to come back for an outpatient visit, because he's already had that discussion. Perhaps a telephone call, but that will be about all. The only thing I didn't describe in that, because it doesn't involve the patient, is the economical efficiencies. The truth is there's a few pounds here and there, and it depends whether in Europe or the UK, when it comes to consumables. But the cost saving is really in the fact that you're not going to the first stage recovery, the amount of nurse involvement is far less, they're not dealing with all the complications of nausea and vomiting or pain as much as they are with general anesthesia. This patient doesn't have to come back for an outpatient visit, so there's a saving to the hospital, doesn't have to be admitted, so there are huge cost savings there as well. There's always a but, and everyone goes, oh, but spinal anesthesia. There's so many problems. And really, of course, myths and fears. It is the misconceptions of spinal anesthesia as I see it. And permanent paralysis, although it's not the biggest thing a patient's concerned about, I think it's one of the things that always comes to mind. So again, I just went to the AAGBR, the college, and of course the NAP3 order, which we all know very well, to actually have a look at some of the facts here. So if you look at the data, and they gave a range, so if you like, pessimistic, optimistic is the way they did it, looking at permanent neurological damage. So the range is 1 in 24,000 to 1 in 54,000. However, only 23% were spinals. So in fact, that's more like 1 in 104 or 1 in 235. 66% actually resolved. So really, your true incidence for spinal anesthesia causing permanent damage is somewhere in the order of 1 in 160,000 to 1 in 356,000. Let's put this into context. A spontaneous epidural hematoma occurs in about 1 in a million. So that kind of puts you where we are. A general anesthetic, according to the guidance from the college, will say to you that your risk of permanent nerve damage is 1 in 50,000. Now, I'm not suggesting that having a general anesthetic means you're 4 times more likely to get paralyzed. I mean, all I'm saying is that it's very unlikely and spinal anesthesia is very safe. And we should be reassured by this data as our patients should be reassured. Being awake, I mean, we have discussed this. The truth is, lots of patients actually want to be awake, and if we give them that choice, they will come and ask to be awake. Look at cesarean sections. Many awake and very happy being awake. So I think perhaps that this is a misconception that we have and place onto patients, and we should at least provide that opportunity to them. Block failure. People always say, oh, spinals, they're going to fail, you know. 1 in 20, I think, is perhaps what some people may consider. And it is true. In the literature, you see up to 17%. But then again, many publications with 0%. There's a great article by Fatz in the BJA 2009, where he goes through all the problems that may occur with spinal anesthesia and suggests that with a good technique, this should be less than 1%. And again, to put it into context, a laryngeal mask will fail 1% of the time, which means you need to deal with the airway, intubate, may take time, and of course, potentially a far more devastating outcome. Spinal headaches. This is a reality, and you shouldn't ignore it. A patient needs to be informed. They must be followed up. So that's something to take seriously. But how often does it happen? I mean, with modern needles, the atraumatic type needle, it really should be less than 1% or about 0.5%. This really occurs mostly in females, and a recent audit at King's Lynn showed in 400 patients, they did have a 1% incident, but none of them were men. Backache, this is just a fallacy. You don't get backache specifically from a spinal anesthetic. The association is with duration of anesthesia, not whether it's a GA or a spinal. So if you have a duration of 4 to 5 hours, you've got about a 40 to 50% chance of actually getting backache. So it's not the spinal. You can park that one. TNS, or transient neurological symptoms, I bet you most people don't even know what that is. And the reason for it is because we haven't used lignocaine for absolute ages. Most of us use bupivacaine, and it is very unlikely to happen. Now, if you use chloroprocaine and prilocaine, they're even less neurotoxic than bupivacaine, so you're far less likely to get TNS symptoms. You will see publications in the literature, that is true, but it is very uncommon. Cardiac arrest and sudden death. If you want to be dramatic, that's what you're going to say, oh, they were going to die. Well, look, there's a risk in general anesthesia or spinal anesthesia. It is true. And I think you've got to understand what you're doing with the spinal anesthetic. And I've looked at a lot of these case reports, and the failure has been in the management of these patients not recognizing the effects of the spinal anesthetic, the sympathectomy or the cardiac effects that may occur. So you do have to understand what you're doing. Now, delayed discharge, that's probably the big one. And that's what a nurse is going to go to you and say, oh, you can't do a spinal on this unit because patients all get admitted. Now, really, why is that? So it's obvious. It's the motor block, so not being able to ambulate. It's urinary retention. Hypertension can be an issue. And these all, as you all know, are just a combination of motor sensory sympathetic block spread and regression. But I think the answer is a simple one, and we saw this yesterday from Dr. Gunz. What you need is to use the right drug for the right patient, the right procedure. It's about communicating with your surgeon and the team and saying, what are you going to do? How long is it going to take? And then choosing the right drug to do the procedure. And this is why you'll see that prilocaine and chloroprocaine, the short-acting spinal anesthetics, are really within the realm of day surgery. And these are the sort of short-acting drugs you should use. If you look at chloroprocaine, I actually find it quite predictable when it comes to ambulation. So once I've done the spinal anesthetic, I hit the clock and I say to the patient, in 110 minutes, you're going to be able to lift your legs. And on the whole, that's what happens. The The patients that I've anaesthetized go home at the same time with the general anesthetic. So I think that ambulation issue is really certainly not a problem. Now, it's pretty obvious if you choose Pyrrolican that lasts a little bit longer, it's going to take a little bit longer before they ambulate. But most of them tend to mobilize within 2.5 hours, certainly under 3 hours anyway. So again, it's not a big issue. Postoperative urinary retention, now that's simply a sensory regression, isn't it? By the time you get S2 sensation, you don't have problems with bladder control at all. So again, you use a short-acting drug, and as it wears off, they get sensation, and they don't get urinary symptoms. In fact, there isn't a single publication of postoperative urinary retention in the literature when using chloroprocaine. Lamelfa and Erskine have done an audit in the UK, which I can't remember, it was a few years ago now actually, but they had 100 patients with no neurological, cardiovascular, or urinary symptoms afterwards. Timo Pallas has 500 patients that he's published, no urological problems at all. I think with chloroprocaine as well, what you see is you don't get a very big spread with it. So it's really good for procedures from sort of the groin and down or below the umbilicus, but they don't get a big sympathetic spread. And I found that it's extremely cardiovascularly stable. And the great advantage with both of these drugs is that they wear off while you're looking after the patient. There's no dumping them on the ward with low blood pressure and a sympathectomy. It's pretty much worn off by the time they're there. So they are cardiovascularly stable and they are absolutely safe. With Pyrrolican, if you're doing an arthroscopy, what you can do is do a unilateral block because it's heavy, put them on the side, and compared to a bilateral block with Pyrrolican, they pass urine 30 minutes earlier. So that's a strategy to reduce your time to actually passing urine. I mean, it is true that there may have to be organizational changes, which you have. You can't overhydrate these patients. And I'd strongly advise not using opiates either. Just use the right drug and you won't need to use an opiate. So I think really that quite clearly to me shows how using the short-acting drugs gets away from these problems of ambulation being a problem, urinary retention, and hypertension. I think something that Sean and I will most certainly agree on is patient choice. And that really is fully informed information about the procedure or the technique and respecting that patient's choice of what they want. Of course, choice and providing this information is really the fundament of the whole consent process. I think it's only until we truly understand and accept the benefits of spinal anesthesia that we can then become the champions of patient care. It's not the surgeon's choice as to what technique we should have. It's not our choice either. It's our responsibility to provide the correct information for the patient to be able to make this choice themselves. If we continue using the same anesthetic technique, we will get the same results, as I showed you earlier. I think patients deserve better pain control, they deserve less nausea and vomiting, and they deserve a better neurological outcome. Anesthesia can do better, and I think with short-acting spinal anesthesia, we as anaesthetists can do better. It's time to stop sleeping, wake up, and smell the coffee. Thank you.